Today's lecture is on analgesics, antipyretics, and anti-inflammatory agents. Basically, this lecture follows really up, utilizes to a certain extent the information from the last lecture on Monday. I made some last-minute changes, like in the last hour. I'm just shuffling orders and slides around. So if the slides you have are a little bit out of order, don't worry about it because you have all the information's there. It's not a problem. It's just I moved the order around a little bit. This other mic. So hopefully this makes sense. I did a lot of changing on this lecture from last year. You'll be pleased that it's not the 64 or whatever slides it was last year, kind of down to about 50. So I think still a lot of slides, but a lot of them are, the information is real simplistic. The reference is Goodman and Gilman, chapter 34. I just wanted to start out today with just a couple of slides about inflammation. We went over on Monday kind of the key things that cause inflammation. So the prostanoids like prostaglandins, etc. And the drugs we're going to go over today basically just block their actions. But I did want to start off with a couple slides on just inflammation in general. Inflammation, we've all experienced inflammation. It's a response to an injury. It's essential for survival. For instance, you twist your knee, you need to not move it or it won't heal, and so it swells up so you can't move it around. If that didn't happen, you'd go running off and do some permanent damage. So inflammation can be a good thing. It's caused by noxious stimuli, including infections. Antibodies can signal it, as well as physical injuries. There's 3 distinct phases of inflammation, and each phase is characterized by the production and release of different signaling molecules. There's an acute phase where you get local vasodilation and increased capillary permeability, and this is a phase that gets driven a lot by the prostaglandins we talked about on Monday. Then there's a delayed subcutaneous phase where there's an infiltration of leukocytes and phagocytic cells, and these are basically there to haul the garbage out, right? Clean up the wound site. And then there's chronic proliferative phase where you'll get tissue degeneration, so the tissue that your body wants to get rid of degenerates, and then you'll get fibrosis. And what fibrosis is you get this overproduction of connective tissue, so the body kind of over-responds, and then that gets stepped back a little bit later on when inflammation is over. There's a lot of different agents that stimulate inflammation. The ones we've gone over in this class include histamine. Remember, histamine gets released from mast cells, stimulate inflammation. Prostaglandins and leukotrienes from the COX and LOX pathways stimulate inflammation, and so do cytokines. Okay, and this happens a lot with the body. If there's a set of molecules that does one thing, there's a set of molecules that opposes that action, and so with inflammation, there are some molecules out there that decrease it, including transforming growth factor beta, which is an immunosuppressant. You guys are familiar with the actions of cortisol, immunosuppressant and an anti-inflammatory molecule that the body produces. Interleukin-10 will decrease cytokine and prostaglandin E formation, so decrease inflammation signaling. And then interferon gamma is going to inhibit the collagen synthesis that's associated with swelling. This slide shows inflammation events in a fairly simplistic form. I kind of liked it. Just thought it was a simple way to look at inflammation. So what happens is there's a wound, and that happens especially with wounds in the periphery. You're going to get bacteria and pathogens that are going to say, hey, there's a good place to grow, right? So they'll enter the wound. Platelets from the blood are going to release blood clotting proteins at the wound site itself. And also, you're going to have secretion of mast cells and other cells, these molecules that are going to cause vasodilation, and some will cause vasoconstriction in the right area. What's going to happen with this is you're going to get an increase in delivery of blood to the area, and also you're going to get swelling to start to form. Your prostaglandins be released, and so you'll get the permeability of blood vessels will increase in some areas. Plasma will flow out. You'll get swelling. Then neutrophils will be there, and they'll secrete factors that are going to kill and degrade any pathogens that are trying to infect the wound. The neutrophils and macrophages are going to work to take care of or get rid of excess garbage, take it out of the area. And then macrophages are going to secrete different cytokines that are going to, among other things, attract the immune system, and also signal molecules or signal cells to do things that are involved in cell repair. We actually have a lecture on cell repair and wound repair, but that's down the road. And then you'll have the inflammation response is going to just continue until a foreign material is eliminated and the wound is repaired. So it's just inflammation in a quick and dirty fashion. For this lecture, I'm going to talk next about NSAIDs, non-steroidal anti-inflammatories. You guys, in your lifetime anyway, are familiar with these things for sure. NSAIDs come in a variety of chemical forms. They're all anti-inflammatory, analgesic, and antipyretic, although to a different extent for each one. Aspirin and acetaminophen get tossed in to the NSAID category. However, they could also be categorized off on their own. If you wanted to be a little bit more specific, you would probably classify aspirin and acetaminophen differently than NSAIDs, just because they have some different actions. And the big thing with NSAIDs is they inhibit COX enzymes, so cyclooxygenase 1 and cyclooxygenase 2. And of course, by inhibiting COX enzymes, you're going to inhibit prostaglandin production. It's possible some of these NSAIDs can also reduce superoxide radicals at high doses, but it's kind of neither here nor there for our purposes. The big thing is that these guys are going to inhibit COX enzymes. COX-1, which you guys know is more of the housekeeping COX enzyme, and then COX-2, which is the induced enzyme. And you can have a lot of problems with NSAIDs, and a lot of that's linked to their effects on COX-1, because you don't want to get rid of all the prostaglandin function if you can avoid it. Okay, and NSAIDs inhibit these enzymes by competing with arachidonic acid as a substrate for the COX enzymes. Okay, so that's a pretty simple mechanism of action. Here's arachidonic acid, here's your NSAID, and then there's a COX enzyme, and they compete for the binding site. Okay. Aspirin, as I said, aspirin works a little bit differently. Aspirin will covalently modify COX enzymes, and that's an irreversible action, and that inhibits their cyclooxygenase activity. So in a little bit different way, aspirin's not competing with arachidonic acid; it's disabling the COX enzymes. Okay. Importantly, NSAIDs don't inhibit the lipoxygenase pathways for arachidonic acid metabolism. So you're still going to get like leukotriene production. Okay. In terms of pain and fever, NSAIDs, they're mild analgesics. They're not. Maybe if you break your leg NSAID's probably not going to work. And they're most effective when pain is associated with inflammation. So, personally, you might have some anecdote about that. I mean, I always think of, when I think of NSAIDs, I always think I've had like root canal that went bad type of thing. You get a lot of swelling. So you can take a hydrocodone for that. It doesn't do anything. But if you take a bunch of ibuprofen, which is going to take care of the swelling, then that actually relieves the pain. So that's when these guys are most effective, is when they're swelling. Okay. NSAIDs also reduce fever, and they do that by suppressing the production of prostaglandin E2, and in particular in the hypothalamus, where prostaglandin E2 is thought to be involved in temperature regulation. So what happens is prostaglandin E2 normally is hypothesized to activate prostaglandin 1 or prostaglandin E 1 or 4 receptors in hypothalamic cells that regulate body temperature. And so NSAIDs are just reducing the levels of that happening, and by doing that, reduce temperature, so reduce fever. And it's worth pointing out that acetaminophen doesn't do that. So acetaminophen, which really can be off in its own category, that doesn't have antipyretic actions. This is a really dumb slide. It shows NSAID mechanism of action in a super simple way. So in this, you have an inflammatory signal is made for whatever reason. Phospholipase is going to come off the membrane, go to the nuclear membrane, release arachidonic acid. Then arachidonic acid is going to try and interact with the COX enzyme. So aspirin is going to covalently modify this COX enzyme, so it doesn't work. Whereas other NSAIDs are going to compete with arachidonic acid for a binding site on the COX enzyme. And so essentially what happens is you get this reduction in prostaglandin production, so you don't induce as much inflammation, and you don't get the associated pain and fever as well. Another thing about these guys, though, is that they can alter thromboxane, or they do alter thromboxane production, which, you remember, thromboxane to a certain extent opposes the actions of prostaglandins and causes things like vasoconstriction and also platelet aggregation. So these agents can or do inhibit that. So what that means is you're going to alter wound formation with these guys too, which is why people take aspirin to keep the blood thin, as it were. It stops the formation of wounds to a certain extent. Yeah, there are some. Yeah. But COX-2 is the one that caused all the trouble. But these things that inhibit both COX enzymes, most of them, there are COX-2 specific agents, right, that we're going to go over. So there are COX-2 specific agents. They have the problems associated with them. Most NSAIDs are, some will prefer COX-2 to COX-1, but a lot of them go for both, including aspirin. Okay, in terms of therapy, yeah. Yeah. What's that? Is it?
I know you can't use it with high fever,
Uh-huh.
but you can still use it. It's the only one that's
Anti-inflammatory. Did I have that wrong? I was looking at that too, but then I just zipped along. I was so busy cutting out slides that I didn't. So I think you're probably right. I'll double check that, but I'm almost 100% sure you're right. I never take Tylenol, so it's crap. So So yeah, sorry about that. Thanks for catching that. It could be. I was using Goodman and Gilman when I wrote that, so they might have a mistake, or I might have just misread it. Okay. But once again, thanks. And I'd like to remind you guys, anytime you see something that looks like it might be wrong, please let me know. There's always a lot of information in these things. Have a no? Okay. That's why I got to screw up more often to keep you guys can talk a little bit. You're so quiet. Once again, in terms of therapeutic effect, NSAIDs are effective against pain that's moderate or low intensity. The main use is, once again, to treat inflammation. These guys will provide symptom relief. It's important to know they'll provide symptom relief, but they usually don't block a pathological progression of whatever's causing the inflammation. So if you have an infection that's causing inflammation, obviously you want to take an antibiotic as well as an NSAID, because the NSAID might get rid of the inflammation, but the bacteria is still going to go to town. And then these NSAIDs have some other uses. Some are controversial, some are not so much. They can be used as cancer prevention so they're thought to reduce the onset of some types of cancer, and that's been hypothesized to be due to they're reducing the ability or reducing angiogenesis, right? So reducing these cancers' ability to attract extra blood supply. They can also be used to increase niacin tolerability, and then some people will take them for their cardioprotective actions. That gets debated. In fact, in this Goodman and Gilman chapter, at one point, I'm sure it's a multi-author chapter. At one point, it says that's a joke, pretty much, that they don't do anything for the heart. And then later on, it says these are used for their cardioprotective effects. So, I think the jury's still out on that one. Really big adverse effect that you can have with NSAIDs worth mentioning is GI problems, GI ulceration, so that you get abdominal pain, etc. And this is largely due to the inhibition of COX-1, because you're inhibiting COX-1 activity in gastric epithelial cells, and so prostaglandins are involved in generating some gastric secretions, some good gastric secretions, some mucosal cytoprotective things that they'll do. So that gets inhibited, and also inhibition of COX-1 can actually cause an increase in acid secretion and the mucosal flow overall. So you won't have that protective layer essentially. This is reduced when you have COX-2 selective agents. NSAIDs can cause problems at the level of the kidney, so they're associated with renal dysfunction. Progressive renal failure can be caused by large quantities of NSAIDs. I mentioned on Monday, it's like these pro basketball players. There's been a couple of them anyway who've had to have kidney transplants because they took so much ibuprofen that it trashed their kidneys. So you can have some kidney problems, and that's due to prostaglandin inhibition, and that'll be particularly harmful in somebody with congestive heart failure or cirrhosis, chronic kidney diseases, etc. Diseases where water regulation is real important. Some more adverse effects with these guys. They can impair fetal circulation, and they can also, because of their actions on thromboxane and perhaps some other actions, they can increase postpartum bleeding. Ray's syndrome, you guys heard of that? There's a Ray's syndrome that's associated with aspirin use in people, I believe it's under 20 years old, have a disease that's of viral origin. They'll take an NSAID like aspirin, and Ray's syndrome can result from that. And then some people are hypersensitive to NSAIDs, different NSAIDs, and so things like aspirin in particular can bother the lungs, so you can get asthma, you get rhinitis, angioedema, So this strange pooling or strange fluid swelling. And then there's other symptoms. So some people are just super sensitive to NSAIDs. In terms of drug interactions, these guys, in particular when you use aspirin with another NSAID, that can pretty easily result in a GI disorder, ulceration, that sort of thing. And then they can also interfere with angiotensin converting enzyme inhibitors, which we're going to go over in a couple days, I think, or a couple lectures from now. So NSAIDs reduce their effectiveness by inhibiting the actions of prostaglandins that cause vasodilation. And the angiotensin converting enzyme with an NSAID, that combination can actually result in bradycardia, so slow down the heart because you get this hyperkalemia going. And that's mostly happens in elderly and diabetic folks. So, NSAIDs have their problems, but obviously they're super useful. And there's probably 2 people in here today who are going to take an NSAID, right? If you're not taking one every day, type of thing. All right, aspirin. And isn't this a nice advertisement photo from the old days? Don't you wish you could live in the 50s again? We didn't know what computers were. Oh, I'd love to not see a computer again for the rest of my life. So, all right, aspirin's obviously a super useful drug. It's salicylic acid. It's most widely used analgesic, antipyretic, and anti-inflammatory out there. It's cheap to make, etc. It blocks COX enzymes, and it may also acetylate proteins. As you'll remember, the way aspirin works is it covalently modifies the COX enzymes, unlike other NSAIDs, which are going to compete for arachidonic acid. Aspirin relieves low-intensity pain from the integument, so in skin and related structures. And aspirin's actions are thought to be, of course, peripheral, although there have been CNS actions that have been hypothesized. And it is, as you know, effective for lowering temperature, etc. There's a laundry list of potential problems with aspirin that I'll go through now. Mostly has to do with its inhibition of COX-1 or thromboxane in terms of bleeding. So you can aspirin will prolong bleeding time, and that's due to irreversible acetylation of platelet cyclooxygenase, and then that results in decrease in thromboxane. So once you don't have thromboxane there to stimulate platelet aggregation, you're going to have longer bleeding time. So, if somebody's going in for surgery or whatever, they'll be told not to take aspirin or other NSAIDs before then, so that you won't continue to bleed too much. Okay, and these guys can result in hemorrhage in some people. At high doses, because of aspirin's effects at the kidney, on COX enzyme activity in the kidney, you get water and salt retention that can occur, and that will cause an increase in plasma volume. So that'll cause peripheral vessels to dilate and alter cardiac output, so that can be a problem. Of course, you can get epigastric distress, nausea and vomiting, ulcers, etc. with aspirin. So, aspirin, obviously, you're losing that the protective mucus that's driven by prostaglandins. High doses can cause liver injury. That's a cumulative effect, so you can't decide you're going to injure your liver today and take a whole bunch of aspirin. You'd have to do that for months on end. The injury in this, it's important to know that if somebody does hurt their liver with aspirin, that injury can be reversed. Okay. Low doses of aspirin are going to decrease uric acid excretion, which is the problem for especially people that have gout, or you could develop gout because of that. And at the end of this lecture, we quickly go over gout pharmacology. However, higher doses have the opposite effect. High doses of aspirin actually lower uric acid levels. Metabolic effects of aspirin, it will include inhibiting some ATP-dependent reactions. And so what happens is you get this uncoupling of oxidative phosphorylation that goes on, that causes metabolism problems, also causes breathing problems. So high doses can cause hyperglycemia and depleted liver and muscle glycogen. Also can reduce lipogenesis. Aspirin can cause increased oxygen uptake and consumption and carbon dioxide production. And that's an effect, you think of it at the lungs. And once again, that's due to this uncoupling of oxidative phosphorylation. So the body consumes more oxygen and produces more carbon dioxide with aspirin. Aspirin can also alter thyroid function, and I made a change at the last minute. I said it decreased the uptake of iodide. That was in Goodman and Gilman, but then I could not find any solid evidence for it, so I took it out. However, aspirin does increase the rate of thyroxine and T3. So T4, T3, you guys remember thyroid signaling molecules, thyroid hormone. Their rate of excretion or elimination can be increased because aspirin will competitively displace those guys from transthyretin and thyroxine binding globulin. Okay. Aspirin salicylates, it can also irritate the skin and mucosa, so you can have a reaction. That can actually be good. Aspirin is used for some skin conditions, so creams with aspirin, it gets absorbed in the skin easily, and it has this keratolytic action. So a lot of skin disorders the keratinocytes are proliferating at improper rates, so aspirin can stop that to a certain extent. So it can be used for some dermatological conditions. Aspirin also, once again, going back to some actions, largely the kidney, can cause a change in the acid-base ratio, which is not necessarily a good thing, right? That's actually due to an increased renal bicarbonate, sodium, and potassium excretion. So a more acidic environment can be created with aspirin because your body's going to excrete, among other things, renal bicarbonate, which is there to help, which balances out acid-base ratio, and also can alter plasma electrolyte profile. And just a couple more pages of problems with aspirin. So in addition to its effects on oxygen consumption, it can directly stimulate respiratory control centers in the medulla, and that actually causes an increased depth and rate of respiration. And then prolonged exposure, you can get medulla depression and a resultant respiratory depression and circulatory collapse. So too much aspirin can really screw up breathing for people, and then that's both by its effects at the lungs, and its effects with oxygen, and its effects at the brain centers that control breathing. Got a question over there? Or am I just hoping? I'm just hoping. Okay. Aspirin doesn't have very many interactions with other drugs. However, it can lower concentrations of other NSAIDs, like indomethacin, etc. Children, in particular, are susceptible to salicylate poisoning and intoxication. So aspirin has to be used carefully in children, and it can cause things like convulsions, cardiovascular collapse, etc. in kids. And also there can be a minor intoxication that can occur with aspirin, in particular in kids, where you get headache, dizziness, etc. And then at really high doses, once again, aspirin can have CNS effects and that are not good. So you can get confusion, delirium, stupor, etc., along with the respiratory depression. Okay, in terms of absorption, distribution, metabolism, and excretion. Just a real briefly with aspirin. It's very rapidly absorbed. That's by passive diffusion, and it can be absorbed in the skin. So that's why you can get, your arthritis rub with aspirin in it that you can put locally. It gets widely distributed, and it's metabolized in many different tissues. Remember, the main site is liver, which of course is where it can cause problems, and it has three main metabolism products. I'm not going to get into those, but just they're excreted in the urine. Okay. Diflunicil is, did I pronounce that right? I think I did. That's a derivative of salicylic acid, so it kind of gets lumped in with aspirin. It's very similar. It doesn't cross the blood-brain barrier, though, which is a good thing. Presumably you're eliminating some of those negative CNS effects that can occur with aspirin. It's more potent as an analgesic and anti-inflammatory than action, but it doesn't cross the blood-brain barrier, so it's not going to effectively reduce prostaglandin E production in the hypothalamus, which is what is the temperature reduction effect of aspirin. So that's a little bit of a difference with diflunicil. Okay, next up, I'm just going to go fairly quickly through some non-aspirin NSAIDs. I just grouped them. They work in a real similar fashion, so this will be quick. Okay, acetic acid derivatives. These guys includes indomethacin, Solandac, and this one that they made so that I couldn't pronounce it. Etodolac. Atodolac. All right, Atodolac. I'm going to focus on that word all day. Okay, so these are acetic acid derivatives, NSAIDs. Prototype is indomethacin. They're non-selective COX inhibitors, so both COX-1 and 2 will be inhibited, and then you'll get the associated problems with inhibiting COX-1. They're more potent than aspirin. However, indomethacin itself or indomethacin, I think, has a high rate of intolerance, so long-term use isn't really possible, as you would expect, and cause GI disorders. Safer alternatives exist. I don't know, you guys could tell me better than I could tell you if Solandac and Etodolac get used more often than indomethacin. So, and then about Solandac, it's a prodrug, so it gets metabolized to an active metabolite. Okay, the phenamates are a different class of NSAID. This should be a movie or something. Name them Meet the Phenamates. Or could have a rock band, the Phenamates, maybe? I don't know. No? Any drummers out there? I need a drummer. Too many guitar players in this building, no drummers. Okay, never mind. Okay, so phenamates are derivatives of N-phenylanthronolic acid. They're COX enzyme inhibitors, as you would expect, that cause GI problems. They also may directly antagonize prostaglandins. However, this is just an hypothesized action. And the phenamates include mefenamic, meclofenamic, and yeah, you guys can read and probably pronounce better than me. So there you go. You guys are all familiar with propionic acid derivatives like ibuprofen, right? So ibuprofen's the prototype. These guys are also non-selective COX inhibitors, have similar actions as other traditional NSAIDs. With NSAIDs, you want to be aware that they can increase bleeding time by interfering with platelet function. And also ibuprofen can compete with other drugs for plasma albumin, which carries around in the blood, and so that can be a problem. Propionic acid derivatives include ibuprofen, naproxen, phenaprofen, ketoprofen. flurbiprofen. Is that right? Did I misspell that? And oxyprozin. So all those guys fall under the propionic acid derivatives category. There's also enolic acid or oxycams, just different category of NSAIDs. These guys non-selectively inhibit COX enzymes, so you can get the problems associated with that. However, meloxicam has a slight COX-2 selectivity, which might make it slightly better. Has similar efficacy as other NSAIDs, and aspirin, once again, can interfere with platelet function. And then the agents that fall into this category are meloxicam, piroxicam, and and this other one. When I was in Idaho, there was a guy who had this little book of pronunciations that, we're basic scientists, right? We don't come across these things every day in our lives. So he'd sit up there and look through his little book, every drug he'd come across that he couldn't pronounce, but I'm not going to do that. So you just have to live with my bad pronunciation. Okay, selective COX-2 inhibitors are a little different. They were developed because, as we've been over, traditional NSAIDs aren't well tolerated. These guys are going to selectively inhibit COX-2 enzyme, which is good. COX-2 is the induced COX enzyme. It's the one that's associated, its activity is the one that's associated with the excessive or large production of prostaglandins. It's associated with inflammation, that sort of thing. So you'd think that would be good. However, some of these guys have been found to cause adverse effects, adverse cardiovascular effects, heart valve issues, that sort of thing. And so some of them have been withdrawn from the market. These guys, just a little bit about them, if they inhibit COX-2, you should have a good idea of what they do. In terms of their metabolism, they are metabolized by cytochromes, so they can interfere with the metabolism of other agents, something to be aware of. So things like tricyclic antidepressants, SSRIs, metoprolol, some neuroleptics, and antiarrhythmics. So when somebody's taking a selective COX inhibitor, you want to definitely look at what else they're taking to make sure that the COX-2 inhibitor is not affecting that negatively. The adverse effects do include those associated with the inhibition of prostaglandin production at the kidney. So these guys can still have kidney problems. COX-2 is expressed in the kidney. So it's induced most everywhere else, but there is, endogenous constitutive COX-2 activity in the kidney, and you can get hypertension and edema from these guys as well. And then this last line shows your list of toxins. Okay, the other category of NSAIDs, tolmetin, ketorolac, and diclofenac. Last set of NSAIDs we cover here. Tolmetin has anti-inflammatory, antipyretic, and analgesic effects. Big issue with this one is GI problems. Ketorolac has significant analgesic effects, but has limited anti-inflammatory actions. One key with this drug, though, is that it can be given parenterally, so you can give it like in IM, that sort of thing, and it can be used as a short-term alternative to opiates. Then diclofenac has been around. You're probably familiar with this one. At least at the time this was written, it was the most commonly used traditional NSAID in Europe. It's a bit selective, or it's selective for COX-2. I did read it can have some COX-1 action, and it has analgesic, anti-inflammatory, and antipyretic action, but it will cause these GI disturbances, and long-term use may result in cardiovascular problems. Okay. Next up is acetaminophen, and this other interesting picture of sculpture of a person made out of pills taking a pill. Modern society, right? Okay, acetaminophen, as I said, acetaminophen kind of is a little bit off on its own category. Gets lumped in with NSAIDs. It's also called paracetamol in the rest of the world. It's the active metabolite of facetin. It's an effective alternative to aspirin as an antipyretic and analgesic. I got it right here. So not as an anti-inflammatory though. Acetaminophen only has minor inhibitory effects on COX enzymes. So its exact mechanism of action, how acetaminophen works, is still not very well understood. But it works, right, for some people. Okay. The biggest adverse effect with acetaminophen is hepatotoxicity, which is why in the news and stuff there's been a push to reduce the amount of acetaminophen that's included with things like hydrocodone, etc. Because people want to take too much hydrocodone, but they're also taking too much acetaminophen. So they're getting best of both worlds, right? Addiction and destroying their own livers. So the biggest what acetaminophen does at the liver is it causes what's called centrilobular necrosis, and it can cause severe damage. You guys are probably aware of this. Fortunately, the effects on the liver are reversible, except of course when somebody's done so much damage that they die. And so what happens is you get this necrosis. This is a liver lobule right here, and you get necrosis in cells around the center part here. So around here is where you get that necrosis, or in this picture, in that area. This is just a slide from Goodman and Gilman that actually doesn't really say much. Just the take-home point is you want to be aware of you should get this in therapeutics, the therapeutic values of acetaminophen versus the toxic values. Okay, and then this chapter covers gout real quickly as well, so I feel like I should go over it. Gold doesn't work, okay, for gout. People like us say you use gold and it won't work or something like that. But anyway, gout, you guys know what gout is, presumably have some idea. It's characterized by the formation of urate crystals in joint tissues. These urate crystals, as you can imagine, you get a big buildup of crystals in a joint. You can get significant inflammation. Turns out that most patients with gout under-excrete urate, so they don't overproduce it, so the body's having problems getting rid of it. And urate crystals themselves are normally removed by neutrophils. Neutrophils then secrete an inflammatory mediator, which has the, perhaps in terms of gout anyway, it leads not such a great action because it leads to a lower pH in the plasma, which leads to an increased crystal formation. Okay, that's the whole system dysfunctions in people with gout. This slide shows uric acid synthesis, and I just saw it. I was going over this a minute ago, or before this class, and I did not realize until then that right here, you should probably, I want you to be aware of this, xanthine oxidase. Xanthine oxidase is a key enzyme in the production of uric acid. So, and if you can inhibit that can be used to treat gout. So xanthine oxidase, and this is xanthine here. The key place I want you to be aware of is xanthine oxidase working is here. It converts xanthine to uric acid. Okay, so be aware of this. Xanthine oxidase is the molecule that causes the production of uric acid. And so to combat this buildup of uric acid, there's different drugs that can be tried. Cold colchicine is one drug, used to be used, not used, I don't think a whole lot anymore, because it has a large number of side effects. Colchicine's a really nasty drug. But it has a lot of different actions, but how it affects gout is not really well understood. So just some of its actions, it stops cell division, especially in cells with rapid turnover, such as in GI epithelium. So you can assume it's going to cause problems because of that. It has inhibitory effects on neutrophils, bring up another host of problems. Does inhibit the release of histamine from mast cells and inhibits insulin secretion. Seems unlikely that those are why it helps for gout. Also lowers body temperature and has a host of other effects. So again, it's not used that much, but it is effective for gout. How it works is not really well understood. Allopurinol, another drug for gout, also gets used prior to chemotherapy. What this does is stops the development of chronic gouty arthritis and progression of the disease. So as you can imagine, you have these uric acid crystals, urate crystals in your joints. It's going to have damage eventually. You can get arthritis. Allopurinol can help stop that. Mechanism of action is to stop uric acid synthesis. So it's a competitive inhibitor of that xanthine oxidase. Okay, and it also will degrade uric acid crystals. Okay, so you think of allopurinol, you think of inhibiting xanthine oxidase, and this guy also has a lot of adverse effects. Resburicase is another drug for gout. It's made from a genetically modified yeast cell line. What it is a recombinant urate oxidase. So it catalyzes the oxidation of uric acid into a relatively harmless metabolite, which is allantoin, which is inactive and insoluble. So it helps get rid of uric acid by breaking it down. Excuse me. Okay. This guy can also cause a lot of unwanted side effects. Probenecid is a uricosuric agent. What this agent does is it, and a couple others, competes with urate for what's called the brush border transporter. Probably best for our purposes, you just know it as the transporter for organic acids like uric acid across epithelial borders. So this will block the transport of uric acid across epithelium. And so what it does is it decreases uric acid reabsorption. And it does this at useful doses. And at low doses, actually, for some reason, it reduces the secretion of uric acid, which is a different effect. So the main thing is it's stopping reabsorption of uric acid. Probenecid also inhibits the tubular secretion of some drugs. So if somebody's on that, worth being aware of, including methotrexate, cancer drug, and also the active metabolite of clofibrate. Also inhibits transport of some agents out of the CSF, cerebrospinal fluid, and then lowers the biliary secretion of other agents. So, as it says in the next line, it's not well tolerated. You know, if it does all that stuff, yeah, it probably isn't going to be well tolerated, and it's not effective in patients, particular with renal insufficiency and other kidney problems. Okay, it does have another use because at a high dose, apparently this decreases the excretion of penicillin, increasing its length of action. So, leave it at that. Sulfenpurazone is also a potent inhibitor of uric acid reabsorption. Also, though, for whatever reason, at low doses, it decreases uric acid secretion, which is not necessarily a good thing. Okay? And this drug also has some adverse effects, GI irritation, etc. Benzbromarone, another uric acid agent or uricosuric agent, it competitively competes with that transporter for urate, so stopping the reabsorption, and it's currently not used in the U.S. And there we go. You imagine that lecture at 64 slides? So that's it. I'll see you Friday. It's okay with me. All right, today we're going to discuss agents affecting water conservation. First, a little bit of an overview. Obviously, maintaining consistent body fluid osmolality is vital. And everybody remembers osmolality from physics and stuff like that, right? I'm not going to go into the lengthy explanation. I asked my friend Taberge if he explained osmolality to you guys, and he said no. And I'm like, he's the chemist, but I don't know. Essentially, for our purposes, I think you can mainly think of it how much water is in the blood. It's not how much blood there is; it's how much water is in the blood. Is kind of at least a useful way to think of it. Okay, arginine vasopressin, also known as vasopressin and antidiuretic hormone, is the main hormone that's involved in water balance regulation in the body. It's a nonapeptide, which means it's just 9 amino acids stuck together. And treatments for water balance disorders in the body often involve vasopressin. And there's also a number of disease states, as you would guess, with something that's involved in regulating water in the body. A number of disease states can affect vasopressin actions, particularly things like diabetes, stuff that affects the kidney a lot. Vasopressin is highly evolutionarily conserved, so it's a molecule involved in water conservation in a lot of different animals, vertebrates, and also invertebrates. Once again, vasopressin is there to mediate the conservation of water. You know, as you can imagine, water is a fairly precious resource. In the Western world, we've got it kind of easy, where we have water readily available. But historically, people would go through times of drought and things like that. So, water is not always there and available. So, the body developed ways to conserve it. Okay. In terms of where vasopressin is made, it's made in the hypothalamus, in the supraoptic and paraventricular nucleus of the hypothalamus, and it's released from the posterior pituitary. And you guys remember the posterior pituitary is the part of the pituitary that's actually neural tissue still. It's just basically a projection of the brain, as opposed to the anterior pituitary, which is attached to the brain by blood vessels. So vasopressin made in the brain, secreted from the posterior pituitary. This slide just jumps right into what does vasopressin do, or it actually does several things. But this slide shows what vasopressin's action on water reabsorption in the kidney, and this is actually supposed to be this is the collecting duct of the kidney. So what we see on this side of the slide is the antidiuretic hormone or vasopressin is not present. So and what we have here is these big arrows are salt reabsorption, and then over here we have urea and water reabsorption. So with vasopressin absent, we'll still get salt reabsorption, etc. Sodium reabsorption. When vasopressin is present, what happens is these pores open up and water is reabsorbed. Okay, so it increases water reabsorption. And also, another effect of it is urea gets reabsorbed as well. So an increase in urea reabsorption. Okay. Vasopressin is released in response to several conditions, including increased plasma osmolality, hypovolemia, and hypotension. Okay, so if you don't have enough water in the blood, vasopressin is going to be released. Vasopressin has many actions at the level of the kidney. Those receptors where you get the pores that cause the pores to open up, those receptors are found in the renal collecting duct. And so what happens is the vasopressin receptor activation causes that increase in permeability of kidney cells to water, and that just allows the water, once again, to move out and be reabsorbed. Vasopressin's other action, when you think of vasopressin, you kind of think it has two main actions. They're a little separate from each other, actually, to a certain extent. It's also a potent vasoconstrictor. And it also has some other peripheral effects that include causing the release of coagulation factors from the vascular endothelium and increasing platelet aggregation. Okay, and then, like a lot of other agents that are made in the hypothalamus, other hypothalamic peptides, it can also act as a neurotransmitter, and it's involved as a neurotransmitter largely in things like water conservation, affecting areas of the brain that deal with that. It also affects adrenocorticotropin hormone release from the anterior pituitary. If you remember, ACTH is part of the HPA axis where cortisol is released. So vasopressin can cause ACTH release, and it's involved to a certain extent in regulation of cardiovascular function and body temperature. Okay, a little bit more about vasopressin, more specifics in terms of synthesis, storage, and transport. Like oxytocin, it's synthesized once again in the supraoptic and paraventricular nuclei of the hypothalamus. Those axons project down to the posterior pituitary where it gets released. It starts out as a pre-pro hormone. As think back, you've probably been over a few pre-pro hormones before when you went into endocrine stuff. So all that means is that vasopressin, when the vasopressin gene is made, so our other genes are transcribed as well, and they're all stuck together in one big long prohormone that then gets cleaved up. So the ones that are made with vasopressin are neurophysin and copeptin. Okay. It gets transported into secretory granules in the cell body where it's being made in the brain, and then those secretory granules travel to the site, from the site of synthesis to secretory terminals in about 30 minutes or so relatively rapidly. It's also synthesized outside the CNS. I'm not going to really get into that, but vasopressin is made in the heart and in the adrenal gland as well. And you see that a lot with these hypothalamic peptides. They're made in the skin as well. Things like ACTH is made in the skin, and you can actually, if you do something like rub ACTH on yourself, it can stimulate hair growth, things like that. So these things have different actions in different places. This slide shows a simplistic version of vasopressin synthesis. Bless you. So up here we have the vasopressin precursor, the pre-pro hormone. So we have vasopressin, neurophysin, and copeptin all together. They get shuttled over to the endoplasmic reticulum where they're cleaved to a certain extent. A signal peptide at least starts the cleavage. Then at the level of the Golgi, they're broken down into vasopressin, neurophysin, and copeptin, and then those guys are in the secretory vesicles that get released. This is the same thing. All Goodman and Gilman. I'm not going to expect you guys to memorize the endopeptidases or anything like that are cleave vasopressin. You should probably be aware they exist, though. To my knowledge, there's no drugs that go after them at this point, so I'm not going to worry about that too much in terms of specifics, but I think, you should realize they exist in case down the road any drug does get invented that alters vasopressin synthesis. This slide shows the sites of synthesis and release of vasopressin. It's kind of simplistic, but up here is supposed to be the hypothalamus, and this would be the paraventricular nucleus right here. And here's the supraoptic nucleus. And so these neurons that make vasopressin send these long projections down to the posterior pituitary, where it gets released in response to changes in osmolality and hypovolemia, etc. Once again, vasopressin is released in response to increased plasma osmolality. Please remember that, increased plasma osmolality. Don't miss it on a test question just because you ran over it real fast. And once again, released in response to hypovolemia, so just a loss of volume, plasma volume, hypotension, and also in response to pain, nausea, and things like hypoxia. So a real simple way to think of it is, and it's true, is vasopressin is released in response to stressors, homeostatic challenges. The osmolality threshold, you don't need to memorize this for the secretion of vasopressin, is 280 milliolemolars per kilogram. You don't need to worry about that. But basically, what you should be aware of is about a 2% increase in osmolality causes a 2 to 3-fold increase in plasma vasopressin. And vasopressin is going to work to rapidly cause the reabsorption of water and lower osmolality again. And what that does in terms of your physical being is it allows for longer periods of where you're not thirsty. You don't need to take in water, which, can be handy when you're living in a desert and things like that, and you want to survive. There's several CNS areas that are involved in the osmotic stimulation of vasopressin secretion, and collectively these guys are referred to as the osmoreceptive complex. And these include the supraoptic nucleus and the paraventricular nucleus, subcortical organ, the organum vasculosum of the lamina terminalis, and the medial preoptic nucleus. Again, you don't really need to memorize those, but you should know that the areas of the brain that are involved in sensing changes in osmolality are called the osmoreceptive complex, and that what they do is they sense changes in osmolality. And you notice how I can actually pronounce brain things, but not drug things. So I think that I'm a neuroscientist, right? Okay, I can take pride in something. Okay, so this slide, in kind of a simplistic form, shows the regulation of vasopressin secretion. So, and here they have it actually as a nucleus tract solitarius. But what happens is in the brain and also in the liver, there's osmoreceptors, and when they're stimulated, they send signals up afferent neurons up to the brainstem, and then stimulate different areas of the brain. Here we have the subcortical organ, the medial preoptic nucleus, the organum vasculosum, lateral terminalis. These guys all work in collusion to ultimately stimulate the release of vasopressin, once again, when these osmoreceptors are activated. Okay. In the brain, there's a molecule called aquaporin-4. It's a water-selective channel on cells that are actually involved in regulating osmolality. So that's actually found on, it's interesting, it's found on glial cells and epididymal cells, not on neurons. And so what that really means is there's a glial neuron interaction in the regulation of vasopressin release and osmolality. So these pores, what they're doing is they're allowing water to come in and, in these osmoreceptors, and so, and that So that's how the brain is sensing water levels, essentially, um, in addition to getting signals from the periphery. Okay, and once again, those peripheral signals are these hepatic portal osmoreceptors, and the way those get activated is actually by salt. And once again, when those guys are activated, the liver, acetylcholine, afferent nerves that use acetylcholine as a neurotransmitter send the signal up to the brain stem, and then that signal gets to the organum, vasculosum, lamina terminalis, etc., paraventricular nucleus, supraoptic nucleus, and what happens at the end of the day is you get vasopressin release. This slide just shows aquaporin structure. So once again, aquaporin 4 is found in the brain, and essentially all it is a pore that they'll be hanging out in the plasma and will be inserted into the membrane of the cell when it's stimulated to let that water in. Okay, hypovolemia, so just loss of total volume, and hypotension actually induce vasopressin by a different route, so it's not via these osmoreceptors, and it doesn't interfere with vasopressin's osmolality regulation. So these are actually, they're two different things. Okay. And the regulation uses different neuronal pathways than osmolality. And so small changes in blood pressure don't cause, don't cause vasopressin release. So what we're talking, I guess the way to think about this is there's a difference between changes in blood pressure that you're going to see with hypotension, things like that, the way that stimulates vasopressin release, and changes in osmolality. Small changes in osmolality are going to cause some decent release of vasopressin. Small changes in blood pressure don't. You need a fairly big change in blood pressure to get vasopressin released. When it does get released, following that, and it acts as a vasoconstrictor, and it's kind of an emergency system. Vasopressin gets released in large amounts when there's a big change in blood pressure, and you get this vasoconstriction and stuff like that, and that helps prevent cardiovascular collapse when you're bleeding a lot. So, you're walking down the street and fall over and fall on a stake or something, and you're bleeding profusely, you're going to get this big dump of vasopressin that happens, and your veins are going to constrict, etc., and that'll help keep you from losing too much blood. Whereas if you're walking down the street and you nick yourself a little tiny bit and you lose little teensy bits of blood, that's not going to cause it. Okay. Vasopressin release can also be stimulated or inhibited by hormones and neurotransmitters. Some agents that stimulate vasopressin release include acetylcholine via nicotinic receptors, dopamine via D1 and D2 receptors, and then also glutamine, aspartate, cholecystokinin, neuropeptide Y, etc. I guess the key thing is if you have a drug like nicotine that affects the cholinergic system, you have a chance of affecting vasopressin release. If you have a drug like, an antipsychotic, which is blocking D2 receptors, it can have an effect of altering vasopressin release. Agents that inhibit vasopressin release include GABA. So that would also mean, by extension, something like alcohol that enhances GABA function is going to inhibit vasopressin release. Atrial natriuretic peptide and opioids. So those all inhibit, the others stimulate. Okay. Pharmacological agents, which I sort of alluded to a second ago, also alter vasopressin release, and they do so by actions on receptors or by changing plasma osmolality. These agents can, on their own, change plasma osmolality. I have a laundry list of agents that can stimulate vasopressin secretion. I think the big one would, you'd probably want to know at least nicotine. High morphine doses can, and so can antidepressants. They can actually cause stimulation. So when you think of it, antidepressants, some antidepressants actually increase dopamine, right? So, and if dopamine receptors are involved in vasopressin release, stimulating it, follows through. The antidepressants can actually cause it to be released. Agents that inhibit vasopressin release, once again, alcohol can do it, phenytoin can do it, low morphine doses, glucocorticoids, and then antipsychotics, things like that. When you're blocking dopamine receptors and not instead of stimulating them. In terms of how the body responds to vasopressin, it's of course going to be through vasopressin receptors. They're all G protein coupled receptors. 3 types exist: B1A, B1B, and B2. You want to keep these straight, at least until you take tests on them. So the B1 receptors are coupled to GQ, and also will stimulate the opening of a calcium channel, and they can activate eicosanoid synthesis. Which is, remember, vasopressin can have an effect on platelet aggregation, things like that. B2 receptors coupled to GS. So, just as a simple question, knowing what you know about vasoconstriction, right? Vasopressin causes vasoconstriction. Which of these receptors are going to be on vascular smooth muscle? You should be able to figure out from just that slide. TikTok. This is the closest I get to a crossword puzzle. What's that? Oh, the question is, if knowing what you know, vasopressin causes vasoconstriction, right? So, knowing what you know about what causes vasoconstriction, previous lectures, what type of receptor causes vasoconstriction, which one of these B1 receptors, which couple to GQ, or B2 receptors, which couple to GS, which one is going to cause which one is going to be found on the vasculature to cause vasoconstriction? B1, right? So the calcium that's released, calcium causing constriction. If B2 receptors were found on the vasculature, they couple to GS proteins. And what happens when you stimulate GS proteins on the vasculature, you get relaxation, right? Just the question was trying to get a feel for G proteins and what they're doing. Okay. In terms of these vasopressin receptors, B1 is the most widely expressed. It's the one, once again, that's found in vascular smooth muscle, plus other tissues, including the CNS. B2 is found in the anterior pituitary. B1B is found in the anterior pituitary, also the CNS and pancreas, and then the adrenal medulla. So B1B would be the one that's involved in ACTH secretion. Okay. B2 is the one that's found in the kidney. So it's found mainly in principal cells of the renal collecting duct, okay, and also on epithelial cells of the thick ascending loop of Henle. And then it can also be found on some vascular endothelial cells. Okay, so pretty easy to try, if you want to keep these straight, B1, vasculature, constriction, so you can, I would hope, be able to easily remember they're going to constriction, so they've got a couple to GQ and B2, think of mainly at the kidney. Okay, B1 activation, once again, results in increased intracellular calcium levels. So with that, you get contraction of vascular smooth muscle. You also get at the level of the kidney, when these B1 receptors are found there, contraction of mesangial cells in the glomerulus, and you can also get prostaglandin synthesis. This slide shows, in simplistic form, V1 receptor activation. So here is your V1 receptor, And when it's activated, you're going to stimulate phospholipase C activity, increase inositol phosphate. Ultimately, you're going to get a release of calcium from intracellular stores. That calcium is going to go then have other effects on proteins, etc. And at the end of the day, you're going to get things like vasoconstriction, platelet aggregation, ACTH release, and also some glycogenolysis. And that's really, I think, what I want to focus on for this lecture in terms of the activation of AVP, the V1 receptor. For the V2 receptor activation results in increased cyclic AMP and protein kinase A activity in kidney cells. Ultimately, what that causes is the insertion of those water channel containing vesicles into collecting duct membranes. Okay, and these guys are the aquaporin 2 are these vesicles that get stuck in the membranes that then allow water to get reabsorbed. Urea permeability is in the renal collecting duct is also stimulated with V2 stimulation, and that helps maximize urine concentration. And then sodium transport in the collecting duct and thick ascending limb is also to a certain extent stimulated, and that's mediated by activation of the sodium, potassium, chloride synporter. So you get a variety of effects with B2 activation. A really big one, at least in my mind, is those water pores and allowing for the reabsorption of water. This slide is from Goodman and Gilman from the old version, shows V2 receptor action. So when the V2 receptor is bound, you get this increase in cyclic AMP production, protein kinase A activity. Proteins get phosphorylated, blah, 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 second messenger system stuff. But a key is these vesicles, these water pores, get stuck into the membrane. They get moved they're hanging out in the cytoplasm. Their movement is stimulated into the membrane, where then they'll allow for the passage of water. This just shows it in a different way. So I'm not going to go over this slide too. It's not the same thing. I guess, well, maybe the one thing that makes this slide useful is it actually shows which side things are happening. So these water pores are on the luminal side, right? So they're taking water in from the urine, and it's getting cycled back into the blood. Okay, this slide shows V2 receptor activation and all the things that can happen from that. It's just in word form. So you get V2 receptor activation, rapid insertion of these preformed aquaporin 2 channels in the apical membrane, principal cells in the collecting duct, and you get an increased permeability of the duct to collect water and ultimately conservation of water. Okay, just going to move on to agents affecting vasopressin receptor agonist and antagonist. They're all nonapeptides, so they're all 9 amino acids stuck together. And what they do is they bind V1 or V2 receptors, and they increase or decrease their activation. And as you would assume, they're used to either enhance or decrease the effects of vasopressin. And I needed something to balance that slide out, so that's pretty simple. Vasopressin receptor agonists and antagonists are vasopressin analogs. Funny how that works. Okay, the effects of these agents, pharmacological agents, on vasopressin action include, once again, there's drugs that increase the antidiuretic response to vasopressin. So these guys are going to alter, to a certain extent, kidney function. So things like NSAIDs, which probably through their effect on prostaglandins, can actually increase the antidiuretic response to vasopressin, so increase the reabsorption of water. So NSAIDs can do that, and within carbamazepine and chlorpropamide. And drugs that are going to inhibit the antidiuretic actions include lithium, and then demaclocycline. It's an antibiotic, but I don't know. So the key is that there's different drugs can actually increase the overall effects of vasopressin. And so here we're not necessarily talking about causing the stimulation of vasopressin release or the inhibition of vasopressin release, but altering the level at which vasopressin can affect how much water is being reabsorbed, how much water is being conserved. This slide probably should have been moved up. This slide just shows vasopressin analogs. I got to even lean over here to see it, so I imagine you guys can't even see it up there. So it's kind of a worthless slide, and I don't even know how well you could probably see it printed out in front of you. But this just shows the vasopressin peptides and what they do. So if you want to just walk yourself through these, I'm not going to ask any by name. So, but for your own knowledge, if you'd like that, I think really for our purposes, just know, vasopressin agents or vasopressin analogs. There's not a lot of clinical use that I know of for agents that directly affect vasopressin, for vasopressin analogs. So the diseases that affect the vasopressin system include diabetes insipidus, which is a disease where vasopressin secretion or the response to vasopressin is insufficient. So it's like diabetes, only with vasopressin. And people with diabetes insipidus excrete more than 30 liters of fluid per day, and they're usually excessively thirsty. So it can be a fairly noticeable thing. And what happens in these folks who have diabetes insipidus is they get low levels of functional AVP, which is central DI, renal insensitivity. Sorry, this is really categorizing diabetes insipidus. So if you have low levels of functional AVP, that's central diabetes insipidus. If you have renal insensitivity to vasopressin, that's nephrogenic DI. That's usually caused by vasopressin receptor mutation. And then drugs which inhibit the effects of vasopressin can also cause DI. So things like lithium, which inhibits vasopressin, can cause DI. So it's why one of the reasons you need to monitor lithium levels and monitor people on lithium. And also, vasopressin can sometimes be broken down too quickly by vasopressinases, and that will cause diabetes insipidus as well. For treatments, basically you use these vasopressin analogs for central DI. So once again, keep it real simple. Vasopressin analogs, they're nonopeptides that are going to, with diabetes insipidus, to treat it, you're going to activate ones that are agonists. Amiloride is used for nephrogenic DI. Remember the diuretic amiloride in that sodium channel that it affects. And what that does is that blocks the uptake of lithium, sodium and lithium in the collecting duct. So lithium can't have so many negative effects. Thiazide diuretics, paradoxically, reduce the polyuria in non-lithium-induced nephrogenic diabetes insipidus. So diuretics and DI can clash. You got to be careful using those. And then indomethacin, has also been tried for nephrogenic DI. That's actually a prostaglandin synthase inhibitor. I don't think it's still being used, but it's at least somebody out there thought of trying that as well. Okay. Another disease, does anybody know how common diabetes insipidus is? I should have got that information. Did Corey happen to say anything about that? No, okay. I'll have to look that up and maybe have that for Friday's lecture. But Another disease that affects the vasopressin system is syndrome of inappropriate secretion of antidiuretic hormone, or SIADH. Symptoms of this are hyponatremia, so not enough salt in the serum, and then hypoosmolality. Osmolality goes too low. SIADH involves obviously the inappropriate secretion of vasopressin, and it mainly occurs when high fluid intake uh, is found in addition to inappropriate AVP secretion, and this can cause, as one would expect, malignancies, but pulmonary diseases, CNS disease or injury from changes in osmolality can cause problems. Pulmonary disease can cause this. Sorry, I have that backwards. CNS diseases, which are going to affect vasopressin secretion, can also cause it. And surgeries can, for some reason, cause this as well. And the book didn't really go into too much why that was. Okay. This thing can also, probably the key point, can be induced by drugs. So drugs that are going to affect the vasopressin secretion can cause this inappropriate vasopressin release. Things like fluoxetine, haloperidol, tricyclic antidepressants, sulfonylureas, etc. Thiazide diuretics, clonidine, enalapril, methyl-dopa. There's a long list of agents that, through their effects on dopamine or acetylcholine, can, and other things that vasopressin is involved in, they can cause this inappropriate secretion of vasopressin. Okay, so, something to look out for if somebody starts having water regulation problems. You want to figure out what they're taking that might be causing that. Other diseases out there that affect the vasopressin system can include congestive heart failure, where you get this pileup of fluid in the heart, right? Nephrotic syndromes, where there's kidney problems, and both these can actually reduce effective blood volume and mess with normal vasopressin secretion. Hypovolemia, which is exacerbated by excessive diuretic use, can actually cause an over-response, the over-secretion of vasopressin, and that then can result in hyponatremia, so not enough salt. So all fits in with the fluid regulation thing. And that's it. A short lecture today. Any questions? Leave everybody dazed and confused. So, okay. Got questions or whatever, let me know. I think if you read through the slides a few times, it makes sense.